Good evening. Welcome back.
Thank you for giving us the.
Oh, you're welcome. This is the last of our this is the old Glaucoma Support Group lecture series we used to do when we did Glaucoma Support Groups a few years ago. So this is the last of the 6 talks, and most of you are familiar and most of you have been here, so you have a good working knowledge on how to manage glaucoma on your own now. So that should be very helpful for you, and it'll also help you have a good background and understanding of what we're going to be talking about tonight, and that's how you deal with cataracts and glaucoma at the same time, and how we think about it. And it's a very common problem I deal with and enjoy dealing with, and by the time we're finished tonight, you'll have a good grasp of some of the issues that you may have to confront or may have confronted or whatever in your particular instance. Let's see, most of you have been here before. There's 2 newcomers over here, right? Right? Just you, okay. Okay, good, okay. And so we always like to do a little bit of enough of a review so you can get a grasp of what we're basically dealing with, so you don't feel lost. But we're going to talk about 2 different diseases that are that occur very frequently together. We're going to talk about. In the first few talks we talked about what glaucoma is and really more like what it isn't. Then we talked about the tests we do for glaucoma, right? Covered a lot. How we diagnose it, the different types of glaucoma, and then we talked about treatment with drops. We spent a whole session on that, and then we had another session on treatment with lasers and surgery when the drops fail, and that set a good basic knowledge of glaucoma. So before we go on and talk about cataracts, I want to do a little bit of review for the people who it'll help you remember, refresh your memory, because it has a lot of relevance to how we deal with cataracts. So what glaucoma is a disease of the optic nerve, and we talked about that at great length. What is the optic nerve? The optic nerve is the cable, in a sense, that connects the eye to the brain, so that if the optic nerve is dead for one reason or another, then the eye is sitting out there without any connection to the brain. The brain thinks it's blind, and that's what happens. Even though the eye may focus light well, the information doesn't get to the brain, so functionally the eye becomes blind. And glaucoma is one of the many diseases that can damage the optic nerve. The optic nerve can be damaged by strokes or injuries, or inflammation, lots of different diseases, but glaucoma is a particular disease that damages the optic nerve in a very particular way. Okay? And when we talk about what glaucoma is and isn't, we always run into the issue of pressure. Pressure is what most people think glaucoma is. We talked about the fact that pressure really is a risk factor for getting glaucoma. It's not the disease itself. Well, there's other things that cause glaucoma or related to glaucoma besides pressure, and those are the genetics. It may be in the family. People who are nearsighted tend to get it more easily. People of dark-skinned races have a probably a genetic tendency that makes them more susceptible to getting it more often and with more severe consequences, a higher incidence of blindness in that particular group of patients. Age is another significant risk factor, and pressure is a risk factor as well. So if you have a lot of risk factors for getting glaucoma, you're more likely to get it. The pressure is the one we used to think was the cause for the disease in of itself, and in some cases that is a predominant factor, but we now know that there are a lot of patients that have glaucoma that have normal pressure, so we can't say that the pressure and the disease are the same thing, although they're related. So and then we go on and we said, well, even though we've now decided that the disease is not the pressure, once we diagnose it, we can't do anything about the other things that seem to be related to it, so we end up treating the pressure. And a few years later, the patients had about maybe 20 visits, and all they've talked about is the pressure since then, and we begin to re-educate the patient by the way we talk about it. They think it's the pressure again. So since it's the only thing we can do about glaucoma, it tends to be a predominant part of our thinking. Now as patients in particular, you think, oh, they come in, how am I doing? The pressure's good today. Oh, great. Pressure's good today. Pressure's good today. Well, how long can you go on hearing that and not think the disease is the pressure? And we always try to emphasize to our patients, well, the pressure is one thing. We have to keep looking at the optic nerve. We take photographs. Those are the tests we did. We draw the optic nerve. We do visual field tests that measures the side vision that is a reflection of the damage that occurs. And we compare it sequentially year to year to see if there's been changes and to see if the disease is getting worse. In spite of what the pressure is, in spite of how well we think it's controlled, we have to keep doing these things because a lot of people get worse even though we think the disease is controlled from a pressure standpoint. So we keep going back and torturing our patients with visual field tests, frequent examinations, etc. So time goes by, and if it gets worse, we decide we have to make the pressure even lower than we've lowered it. And we use medications. We went through all the medicines, and there's a green sheet in the handouts that you have in that packet there that has a list of all the medications and how they work, some of the side effects. So we start using drops generally, and sometimes we use lasers earlier, and in some parts of the world, if the disease is very advanced, particularly in Europe, they're more aggressive. They'll go right to the operating room earlier than we do. In our country, we generally tend to use medications first, and then if that doesn't work, we do surgery. Well, so now we're sort of up to where we were. We do surgery. We described in detail the surgery and how it's done last time, but everything's aimed at lowering the pressure. So that's what we tend to do because we don't know what else to do. Someday maybe we'll be able to make the optic nerve more strong in a sense, maybe more resistant to whatever's damaging it by different types of treatments. And maybe we won't be so focused on the pressure in the future. That's possible. I say in the next 50 or 100 years, I think we'll see that kind of a approach to diseases like glaucoma with nerve damage that's progressive. We'll find other ways of protecting the nerves in a sense so they don't get damaged even though the pressure might be high. Okay, so that's sort of a real short summary of what we talked about and how we manage glaucoma. So let's go and talk a little bit about cataracts so we can then talk about them when they occur together. So a cataract is inside the eye. It's a structure inside the eye. If an eye is looking at you, you see the eyelid, you see the pupil, colored part of the eye is here. Let's say, and there's the whole eyeball. If you took out the eyeball, it would be looking at you like that. There's the whole eyeball. But let's say we cut it right down the middle and then we open it up. And what we see is the eyeball, the side view of the eyeball, and this would then be the cornea would be a little more curved. Cataract is what happens in the lens in the eye. The lens has a role in focusing light rays that come in. So they come to point focus on the retina. It plays a role in it. Actually, most of the light's really focused by the front surface of the eye. And then the lens adds some more to it. And when you're young, the lens focuses so you can see distance and near without bifocals. And as we all find out as we get older, that's not so easy, and you have to wear reading glasses because the lens loses that flexibility. But anyway, also as you get older, the lens tends to turn a little yellower and get cloudy. And if that lens gets cloudy enough, we call it a cataract. So the cataract is not a whole lot different from the lens. The cataract actually is the normal lens in the eye. I hear a lot of people come to me and say, isn't a cataract a growth on the eye that we're going to take off? No, it's not. It's inside. You have to go take it out. Okay, so there's a variety of ways we can remove cataracts. The techniques for removing them have evolved dramatically in the past 15, 20 years. We now do it much more safely with small incision, no stitches, no needles now, just drops to numb the eye. But all in all, we go into the eye and we take out the lens. And we have to, if you take it out, you can imagine that the light rays won't focus as well on the retina. So you have to replace it. Now you folks are all old enough to remember your parents' generation when they had their cataracts out. What did they wear afterwards? heavy glasses, and that was because you had to put the lens in front of the eye to take the place of the lens that was in the eye. And now we have intraocular lens implants that do the same thing for us, so that today not only can you not have to wear the thick glasses, but you may not have to wear the moderately thick glasses you wore before, because we can correct the nearsightedness or farsightedness to a pretty close to no glasses for distance, unless you have astigmatism, and we're even working on techniques for that too. So we're moving toward no glasses as a result of our cataract surgery. That's another issue. But when the lens comes out, you have to replace it with we call it an IOL, intraocular lens. Well, they're made of different materials. They're made of, one of the materials they're made of is most commonly, in the past we used what's called PMMA, polymethyl methacrylate. That's a plastic. And that lens, I understand that lens material was picked because during the Korean War, when they made jet planes, they had cockpits, over the pilots, and sometimes the pilots would get shot, and shrapnel from the cockpit would go into their eye. And apparently the eye seemed to tolerate it very well, didn't even reject the plastic substance at all. So they said, hey, this will make a good material to make implants out of, and it really was a good material. The eye doesn't seem to mind having this plastic material in it, so it doesn't react to it very much. Now, we also make them in fold. PMMA is hard. It would break if you tried to fold it, which we like to put them in through smaller incisions. We like to roll or fold our implants up so we can stuff them in through a tiny little hole. And we started making them not too long ago out of silicone. So that's a softer material. You can manipulate it. It's flexible. And now they're making lenses out of other materials. They're making them out of acrylics. And they're making other types of implants that are not as popular. And I think in the future you'll see that this list will get longer and longer as we find better and better materials. So we try to go into the eye by making an incision now on the side of the eye, make a little incision here. We go in with the pupil dilated. We open up the capsule of the lens, suck out the inside of the lens, and leave the skin of the cataract in there. I'll get back to astigmatism in a minute. But you go in and you open up the skin of the cataract, shell out the inside of it, leave the skin intact, and put the implant right there. Put it right inside the eye. And what's nice about it is it's sort of sequestered away from the other vascular structures in the eye. It has a little healing sort of skin around it, holds it still. And skin of the cataract. It's just sort of a capsule. It's not really skin like skin. It's a capsule. Of the cataract. You leave the capsule. Yeah.
Where did they get the name cataract?
That's very much argued. Not a good sign. Cataract often means water. If you look at the waterfall, right? And I don't know. I don't think anybody really is sure. It's still debated today. So we take the cataract out by shelling out the contents of it, putting the implant in to do the focusing. And then we don't even have to suture up these small incisions, because the pressure of the eye, if the wound is designed right, will sort of hold it shut for you. And you don't have to put any stitches in or anything. So the surgery proceeds very quickly now, and it can be done, I've heard, 5 minutes. I'd say when I do them, it takes a bit longer. I just don't try to rush my way through them. I guess if somebody's a high-volume cataract surgery, there's money and time in getting it done quicker. And some efficiencies will probably gain by doing lots and lots of them. Nonetheless, the speed has gotten better for everybody, and it's been a lot safer. You don't have to give people a lot of sedation in the vein anymore. It's in and out. You go home with the eye open. In a lot of cases, you can go home with the eye open and use it right away, which is very appealing, very rewarding. The patients are very happy with that technique. So that's how the cataract's done. And you mentioned the skin. I'm glad you did, because you asked if it was clear. Later on, the back surface of that cataract eventually starts to cloud up. An average of maybe 3 years, depending on, some people think these acrylic lenses have a lower incidence of that occurrence. remains to be seen. But once the cataract comes out and the skin's, I'm going to blow up this area right here. The implant might be sitting inside this shell. This gets cloudy. Because the tissue that you take out of the cataract, you always leave a few cells behind. And those cells think they have something, they have to still keep growing, and they eventually grow across the back behind the implant. So we can then go in. We talked about lasers last session. We talked about a YAG laser. And we can shoot the laser beam through the cornea and make little explosions in there to rip this little thing open without damaging the implants. Very nice. It can be done. Doesn't even scratch the implant if you're careful. And it clears up the view again. Now, some people call these secondary cataracts. So we call them, I like to call them posterior capsule opacities. Because I don't like people to think their cataract came back. It really is not the same as a cataract, but it's often called a secondary cataract. And the fact that it's done with laser and often called a cataract leads a lot of patients to think that they had their cataract removed by laser. And I have people that come to me and they say, you take out my cataract, it'll be done by laser. And I say, no, no, no. They go, oh, yeah, I'm sure Dr. So-and-so did it with a laser. I said, well, you go ask him, because he probably did a secondary cataract with a laser, and it wasn't really the cataract. But it's a very popular misconception that people have that cataract's removed by laser, but it is not. The cataract itself has to be removed from the eye. You have a question? Does the secondary membrane always happen, is your question? No, it doesn't always happen. It happens on, in my hands, it's about an average of 3 years. I'd say half the patients need it. Yeah, half the patients. Now, some people need it done a month or two later after the surgery is done. But the average person doesn't need it for a number of years. And some people I've operated on many years ago, and they have no sign of it. So it's a variable thing, and it's not considered extremely dangerous. But we'll talk about that in the context of glaucoma in a few minutes.
How long does that last, secondary?
How long does it last? It should last forever, except in a few rare cases when those cells, they keep growing and they sort of grow across the back of the implant again anyway. So occasionally you have to repeat it, but generally it's considered to be a permanent end to the whole issue of cataracts.
Can you use the YAG again?
Oh yeah, you could go back and use the YAG laser a second time and make it. And sometimes we make the holes a little small, and we then have to go back and make them a little bigger. Sometimes the front surface of the membranes will shrink down, and you have to do some work on them. As long as these membranes are not blocking the vision and the clarity of the vision, we tend to leave them alone. Now, there are some risks in cataract surgery. When you go into the eye, you sort of, everything, you can imagine the implant's not as big as the cataract. Things move forward. There's a chance of retinal detachments, retinal edema in the macula. These are risks. In other words, the cataract surgery can cause macular edema. That's in the back of the eye. The macula is part of the retina right here where you're trying to see with. You can get a retinal detachment. Right, detachment. It can make the pressure go up even in a person that doesn't have glaucoma. Increased pressure. It can make inflammation. It can do a lot. You can cause the cornea to be damaged and need a transplant. So it's not without its risks that a cataract's removed. Now, these risks are really important to remember. Unfortunately, a lot of people don't. It's not spoken of probably enough. A lot of people have the impression from reading advertisements that cataract surgery has no complications. There's no risks at all in having it done. But if you ask around, you'll probably know a friend or two that's had some problems. Fortunately, most of these things can be fixed. And if it's attended to early and you're a little lucky, you end up with a good result nonetheless. Another problem that we run into is that people who have a cataract that often have other problems. Glaucoma being one of them, but I'm going to go around it and talk about some of the other things like macular degeneration. I know we've spoken about that before. The macula can already be not so good. If that's not recognized ahead of time, you may have an unhappy person who's not seeing as well as they would like. Sometimes you can't, the cataract's so dense you can barely see the macula. It can be a surprise afterwards. So patients who have surgery should be told, you know, what the chances are they'll see well. So they need to be evaluated for visual potential. In other words, if they have bad glaucoma, then they're not going to see better when it's removed. The patient should know that, and they should influence their decision. If they have macular degeneration, they should be told, yes, you have macular degeneration, but it looks as though when the cataract comes out, you will have some improvement anyway that may be worthwhile. Okay? So these are things that people need to take into account. Now, one of the things that we'll be talking about as a problem with glaucoma is as complications of cataract surgery. The cataract surgery itself can be a little riskier if you have glaucoma. But I want to finish talking about cataracts in of itself so that we can then add the glaucoma in. So let's see, do you have any questions about cataract surgery? You had some question about astigmatism, but I'd really rather not address that right now. I'd like to get to that afterwards perhaps, because it doesn't really relate directly to this, I don't think. Okay, ask me that afterwards, okay? Please, okay? Thank you. That's another whole topic. Yeah, yeah, yeah. It's sort of like one of the reasons you wear glasses, and we try to adjust the cornea sometimes, or adjust our wounds in such a way to eliminate the astigmatism. Okay, floaters you're asking me about. Floaters are in the vitreous gel back here. Removing the cataract, some people get floaters. It's sort of related to the retinal detachment risk. You're saying if you have floaters before cataract surgery, will the floaters go away? Well, probably not. They may change. They may be less noticeable. As they move away from the retina, they may not be as noticeable. But it's not done to relieve the floaters. You don't take out a cataract to get rid of the problems you're having with floaters. Okay. So we talked about the risks. We talked about the surgery a little bit, and the implants, and the membranes afterwards. Okay, let's go on and talk about how having glaucoma can interfere with the whole process, or how do you deal with it? Well, if you have glaucoma, there's a couple different aspects that need to be looked at. Number one is it's often a little more difficult to remove the cataract than somebody that has glaucoma. For one reason, the pupil doesn't dilate as well. Now remember that cataract is behind the iris. It's right there in the pupil. So the pupil has to dilate well to let you get at the cataract. People with glaucoma don't seem to dilate as well. In particular types of glaucoma, particularly pseudoexfoliation is a type of glaucoma. I really didn't get into details with that, but that kind of glaucoma, the pupils don't dilate well. Often also people have been taking pilocarpine, which is a green top drop, which makes the pupil smaller over many years, and the eyes don't dilate very well. Now, we don't use pilocarpine as much as we used to, so I think in the future that won't be as much of a problem. But if you look at statistics on complications from cataract surgery, in other words, you take all the complications that occur, you'll find that a lot of the complications occur in patients whose pupils didn't dilate well. Okay? Does that make sense? So therefore, having glaucoma and having a tendency to have the pupil not dilate a little greater makes your chances, if you have a cataract and have glaucoma, if you have glaucoma and have a cataract removed, your chances may be a little higher that you're going to have complications just for that one factor alone. Now the other issue is, if you have glaucoma, you often have high pressure. One of the risks in opening an eye to take out a cataract is if the pressure is very high and you suddenly lower the pressure, there may be a slightly greater chance that you could have a devastating complication where hemorrhage would occur in the back of the eye. In other words, a blood vessel under the retina here could burst with a lot of pressure from the blood pressure in there, which can literally force the contents of the eye right out through the incision. It's a very devastating complication that rarely occurs, but the chances of it occurring are greater if somebody has glaucoma. Now, that can be dealt with, but it has to be dealt with ahead of time. We can give them some strong medicines in the vein. Now, this wouldn't apply if somebody has normal pressure glaucoma, right? It makes sense. Normal pressure glaucoma, you don't have high pressure. That's one of the types of glaucoma we talked about where the pressure isn't up. Remember I mentioned that pressure and glaucoma aren't the same because some people have glaucoma with normal pressures. So if they don't have high pressure, then that issue is not going to come up when they have the cataract out. But let's say that somebody's got a pressure that's controlled to 20, and they're on 3 medications, and now they're going to have their cataract out. So there's a good chance that the pressure is going to be higher than 20 the day they have their surgery. They may, in the flurry of getting ready for the surgery, forget to take their drops. Their pressures may vary, and they may be 25 one day and 15 another day. So if the pressure is higher, plus we dilate the eye, which may counteract and some of the pressure drops they're taking. And in a lot of glaucoma patients, when you dilate the eye, the pressure goes whoosh. Okay? So you get them on the operating table, you don't realize it, you open up the eye, and now you got a better chance that you're going to have problems during the surgery of a lot of different types. So that whole issue needs to be addressed by either giving drops before the operation or some special medicine in the vein that takes fluid out of the eyes and makes the eyes softer. You can actually plan it that way. Okay, so there are ways of getting around this. I don't want to make it seem like too severe a problem because it's not everybody with glaucoma that has it that bad that this is a big issue. But it's something that needs to be thought about, but it makes the chances a little higher. Now, so you have a patient whose pupils may not dilate as well. And then there's another issue. Another issue of why they're needing the cataract out in the first place. Let's talk about that. I didn't talk about that with cataracts, but let's talk about that a little bit. Why do you take out somebody's cataract? How would you know when would you take it out? When you can't see good and you have glare is what you said. Right. Some people have cataracts out, and they all have different reasons. Some people can't see road signs well. Some people want to drive at night. Some people have trouble reading. But the bottom line is what you said. The cataract shouldn't be removed unless it bothers you. It affects you in a functional way. In other words, you should have a complaint that says, can't see the TV, can't read road signs, can't see the golf ball after I hit it. I mean, a lot of those kind of complaints. There should be a reason for doing it, not the fact that the cataract is there. The fact that the cataract's there, even if the vision's somewhat affected, that in of itself is not a good reason to remove it. Okay. Remember we talked about the drops that make the pupil smaller. That can have a devastating effect on the vision. If you have a cataract here, back here, and the pupil's made very small in front of it, the pupil comes down, and this little hole here is the pupil. If that's smaller, it can, depending on the type of cataract, make the cataract seem a lot worse than it is. Okay, so sometimes if somebody says, oh, I need my cataract out, I'm not seeing so good, one way to solve some of their problems is to change them from one type of drop that makes people smaller and get rid of it. So that people can open up and they say, well, I can see better now, maybe I don't need my cataract out. So sometimes we don't even take the cataract out. Okay? So that's one of the issues that comes up with the cataract surgery. Do you have to have it out? There's 3 ways of dealing with the cataract and the glaucoma. I'm going to just sort of lay them out for you. One is just do cataract surgery alone. Just do cataract surgery. Another way of dealing with it is to do cataract and glaucoma surgery. At the same time. Or it could actually be done the glaucoma. Another option here would be to do just glaucoma surgery first. Just glaucoma surgery. And in a separate sitting later, then do the cataract later. Well, people don't like that because it takes 2 stages. But sometimes, in rare cases, well, I'll do it that way. But in the past, a lot more people did it this way. But today we tend to do, instead of staging them, we'll do them together. So that's option 1, option 2. And the third option is no surgery. Now, that option, I just spoke about it. If somebody's on those small drops, maybe you can find a way to make their cataract bother them less. Maybe you don't need to do it. Okay, and sometimes maybe just do a glaucoma, no cataract surgery. Maybe just do a glaucoma operation, get them off all their drops as one alternative, and maybe they won't need their cataract out. It gets to be a little confusing sometimes when I get sent a patient who has very high pressure and they need a glaucoma operation. And they happen to have a cataract, but the cataract's not very bad. So that's one of the options we tend to look at is no cataract surgery, just do whatever you need for the glaucoma. So, but these are really the three things you have to deal with. Let's say you know you need your cataract out. There's no doubt about it. It's not the medicines causing it. So we have to deal with these two ways of dealing with it. Now, why would we do this sometimes one way and then the other? Now, what it's going to come down to is really knowing a lot about your glaucoma. And if you look at the blue booklet that I gave you, it talks about this in there. In fact, I'm going to get one of them. Where's that? I need one of those books back there. No, he got one for me. Thank you. Thank you, though. Okay. Now you'll see in there it talks about how severe is the glaucoma, how well controlled is the glaucoma, how much medication does the patient take and what medication intolerances are there, has previous glaucoma surgery been successful? These are the questions you have to know the answers to. The presence of eye disease, other eye disease like macular degeneration, health of the other eye. So to answer the question as to what you do when you have glaucoma and a cataract, you have to know a lot about your own glaucoma. Now, if you've been here before and you've been to the talks, you now know how to go to your doctor and find out some of the answers to these questions, and you might know a lot of them about yourself, but particularly important is the first question: how severe is the glaucoma? And you'll see it that the way you can tell really is you look at the optic nerve, but particularly look at the visual field. And remember, I came and I had some visual fields that had a lot of dark on them and some that weren't so dark. If there's a lot of dark on them, it means your glaucoma is probably pretty severe. Now, there are reasons why it might be artifact. If you have a lot of cataract, that can make the field look darker. If they put a new printer, a new ribbon in the printer, it might look darker when it's printed. And particularly if it's faxed and copied and then faxed. We see this problem all the time. I get a field and I look at it, my first reaction is, oh my God, it's so dark. And then you look at the numbers and you find it's not as bad as it looked. So how severe the glaucoma is a really, really important fact to know. Now, what can happen, remember I talked about the pressure can go up. Risks, it can go up. It can go up on two bases. It can go up temporarily, and less commonly it can go up permanently, even in a patient that doesn't have glaucoma to start with. It's not uncommon for people who have no glaucoma to have cataract out, routine cataract surgery, and the next day their pressure is high. Maybe go up to 30 or 35 or 40 even. For a lot of different reasons it can happen, right. And you know, that's a little uncomfortable to the patient sometimes, but if they don't have glaucoma and it goes down in a reasonable period of time, it doesn't hurt them. The eye can tolerate the pressure. Now, if somebody has severe damage in their glaucoma, their eye may not be able to tolerate that pressure without suffering some loss of vision very quickly. So if you have severe glaucoma, sometimes we'll choose to do the combined operation just to have a safety valve for the pressure. Because if you remember, a glaucoma operation is a hole in the eye and it lets fluid out, and there's a very good chance that when you do that, the pressure will tend not to go up to 30 or 50. Plus, if it does, you can quickly activate the glaucoma operation or just wiggle it with your finger a little bit and a whole lot of fluid will come out and the pressure will come tumbling down. When you don't have that option, when you have no glaucoma operation to work with. So if you have severe glaucoma, we're going to tend to err on the side of doing a cataract and a glaucoma operation at the same time to be safe. That's for the short-term rise in pressure.
What happens if it's unplanned glaucoma surgery when you have a cataract?
Okay, say that your question is, what happens if the...
Yeah,
If what's not planned? If the glaucoma,
The glaucoma was not
in other words, they don't have glaucoma going in, you're asking, right? And the pressure goes up afterwards?
planned. No, not much.
Okay, well, I'm not following your question at all.
I thought within the operation itself, how close would they get to this channel?
Well, they're working near the channel, but that's not the issue you're asking. So you're saying somebody who has glaucoma, I'm sorry, a cataract operation, doesn't have glaucoma and the pressure goes up. Is that what you're asking?
No, I just wondered how they can get to that tube that they open up by just doing cataract surgery.
I mean, why does the cataract surgery make the pressure go up? Is that what you're asking?
Do the pressure.
Okay, I'm not following you. Ask me later. I think I need to know a lot of details about your particular case.
All filters left.
You had an inadvertent,
Yes.
okay, you had an unplanned glaucoma operation occur as a result of a cataract operation.
Right.
Different scenario. Well, that wasn't planned. You didn't have glaucoma to start with, so that's a complication of cataract surgery that's way down here on the list. Hardly ever occurs, but does. That's another issue that's not part of today's talk. So you got a free glaucoma operation even though you didn't need it. That can be a real bugaboo. That's a separate talk later. Okay, so we talked about how severe is the field loss. They're very important. And then how well controlled is the glaucoma? Let's say you're on 3 medicines or you can't tolerate any medicines and your pressure is too high going in. So now you know a little bit about it. So what do you think about that situation? Here you are with uncontrolled glaucoma already and you're facing a cataract operation. And you know that this higher pressure can occur. What do you think the likelihood of having this occur if you're already uncontrolled is? Very high. Very high. If you're already uncontrolled, it's very likely, I'd say more than likely, the pressure is going to go way, way up. So what you do often is do the combined operation. Now, there are certain scenarios where you might not. You might choose to do maybe a laser operation and get the pressure down a little bit and then take out the cataract. Or you might say, well, gee, let's say it's not controlled, but the earlier question, the glaucoma is not severe at all. Well, you might take a chance and just take out the cataract. Now, it gets a little tough. There's a lot of gray area which you do. Now, how do you think doctors make the decision whether they should do this or do that? How do you think they make the decision? It's on the fly, and it's based on their experience. And a lot of doctors do cataract surgery, but a lot of them don't like doing this for a lot of reasons, because there's a lot of complications, and we talked about that last time, that can occur from the glaucoma surgery when it's done. So there are some risks in doing it, and they're a little hesitant to. So they might, in that situation I just painted for you where the glaucoma is not controlled but there's no damage, we also know sometimes when you take out the cataract and just do the cataract that the pressure will come down once you get over this pressure rise in the early stage. It'll often come down because you took out the cataract. So it's not a bad plan to hope that you can get away with that. But it's a very bad plan if you don't explain this to the patient ahead of time.
What makes, when cataract surgery, what makes that?
Good question. You're asking why would the pressure go down when the cataract is removed? You know, and that is not really understood. But it's clearly observed, and the pressure may go down for quite a long period of time afterwards. So I have this situation come up a lot when I have patients, particularly glaucoma suspects. Now, you may not remember that, those of you who weren't here. Remember, a glaucoma suspect is a person who has a risk for glaucoma but doesn't have any optic nerve damage, right? So let's say their pressure's high, which maybe I have. Here's a perfect example of somebody who I purposely wasn't treating. Their pressures are above normal because I thought their optic nerve could tolerate it. Now they come in with a cataract. I've never even treated this person, never wanted to. Well, in that kind of situation, I'm going to just take the cataract out because I know that the optic nerve can tolerate the pressure, and I'm going to tell the person ahead of time, you know, you have a tendency to glaucoma. There's a chance I might take out your cataract, and the pressure could stay permanently up, and we might have to go back and do a glaucoma operation. You have to tell people this, though, so they don't get mad afterwards, right? Right? You have to tell people this. So I'll still recommend we just do the cataract operation because they don't have any damage and there's some risks here, and we figure we could always add some medicine afterwards. If they've never been on medicine, there's a good chance the medicines are going to lower it. Follow me? So you have to think it through logically, but you notice where I made my decision from. I went back to that first question, how severe is the glaucoma? Most of the decisions go back to how severe is the glaucoma. So if somebody has uncontrolled suspect status, it's not as bad as if they have uncontrolled severe glaucoma status, or even moderate glaucoma. If they're uncontrolled and they have real damage of the optic nerve, I'm going to err on this side because I want them to end up, not forgetting about the short-term prevention, I want that glaucoma operation to work for a few years, maybe 10 years, keep it controlled. Especially if they're going in uncontrolled to start with. Or what if they're on 5 different eye drops? Sick of taking the eye drops. Most people don't like the cost, the inconvenience. They may have to take 15 different drops in their eye every day to keep their pressure controlled. And if I say to them, well, we're just going to take out your cataract, but if I do this glaucoma operation with it, there's a good likelihood you're going to be on a lot less medicine. They usually go, sold. So you can see there's a million factors. So every one of these possibilities is another permutation. Now what if they can't tolerate any medicines? That's another reason you sometimes would err on this side. Here's another issue you look at. If they've had let's say they've had a glaucoma operation and it didn't work very well, or it worked very well, that's going to influence how you do, what you do. In other words, if they had a glaucoma operation that was extremely successful, they're very happy, they're going to be asking for that surgery in their other eye. Or maybe they had a glaucoma operation in that eye 15 years ago, and now it's sort of partially working. Here's another fact. If you have a glaucoma operation that's working in your eye and you have the cataract out, there's a fairly significant chance the glaucoma operation that was done will stop working. Okay. Let's say you've had a glaucoma operation in an eye and it's working like a charm for 5 years, 10 years. And now, a couple years later, it's not working as well, but it's still working, but you have to go back to some medicines. Now the cataract comes on and you have to take out the cataract. But the glaucoma is controlled on a couple of medicines. It gets complicated, right? Okay, now what do you do? Well, if you just take out the cataract, there's a good chance that the glaucoma operation that was done before won't work as well. Not maybe 30% chance it'll stop working as well.
Even though in the other case, just doing a cataract surgery could lower.
Yeah, that's right. Isn't that interesting? Now, why do you think you're asking, even though when we talked about cataracts before, sometimes it lowers the pressure? Well, there's 2 factors going on. One is, how much is the glaucoma operation keeping the pressure down? And it's not always predictable whose eye is going to go, the pressure, in whose eye the pressure is going to go down when the cataract is removed. You follow me? So it's not predictable. You can't say, oh, your pressure is guaranteed to go down because it's not predictable. Sometimes it goes up. Sometimes it's unchanged. Hang on. So it's hard to predict that. And then on top of that, you have this other X factor of if the glaucoma operation is really contributing to the pressure being down and the cataract operation has a negative influence on that, you don't know which factor is going to predominate there. Anything can happen, right. So in that situation, we go back to the first question. How severe is the glaucoma? Because if the glaucoma is very bad and it won't tolerate that likely chance it may go up, we may choose to do another glaucoma operation right at the same time, even though there's one there that's sort of working. But it's based on the fact that the glaucoma was severe. Now, if the glaucoma is not severe, and you were the patient, you might say, well, I'll take my chances, I'll see if I can get away with it. But in the back of your mind, you're saying, well, I know I may have to have that glaucoma operation next year or the year after anyway. Or maybe next week. Hopefully not. But invariably, I get referred patients to me who've had a cataract operation, and even with good intentions, The pressure, they come back with a pressure of 40 or 50. Right, and it's very scary. And I feel bad for some of those patients because sometimes I think they were probably told, but in the back of their mind they weren't really planning on this possibility. So I like to take my patients and rub their nose in it a bit. Tell them to think about it a little bit. Because I don't like when that happens. It's a very unpleasant experience for me and the patient. But I think it's important that people know these kinds of things when they make a decision like that. It's very important. But it really comes back again to how severe is the glaucoma. You'll see I'm going to keep coming back to that, because that's going to dictate a lot of our concerns about this pressurized issue. Now, you had a question.
Yes, how many times can you go in and do that glaucoma surgery?
How many glaucoma surgeries can you do? You can do a lot of them. You can, as long as you can find a room on the eye to do another one, you can do it. You can easily do 3 or 4. 3 is pretty, 3 pretty reasonably in most circumstances. But you realize you can also put a tube in the eye if you run out of places to make a hole. So that's like another kind of a glaucoma operation. We talked about that last time. What the tube does is it takes the fluid further back. But it works in a similar kind of way.
Further back, where does it go?
It goes up on top of the eye, behind the eye pretty much.
But you can't reopen the previous hole.
Yes, you can reopen a previous hole sometimes. You can, well, I don't have a drawing of the glaucoma operation there, but on your drawing, you can take a needle and puncture the bleb a little bit and get more fluid to come out. It doesn't always work, but you can sometimes revise them. You can revise them surgically sometimes. Okay, let's see. I think we've covered pretty much. Oh, we haven't covered one other thing. We sort of talked about it last time. And the last part of the book, it talks about medications which affect wound healing. Remember we talked last week about the anti-cancer drugs? We talked about 5-fluorouracil and mitomycin C that are used to influence the glaucoma operations. Well, when you do a cataract, here's another important factor. When you do a cataract and a glaucoma operation together, generally, the glaucoma part of the operation doesn't work as well as if you would just do a glaucoma operation alone. Now, we don't know why that is also, but that's known to be true. So we generally are much more liberal with the use of those, what we call them anti-metabolites, but they're cancer drugs. And when we do our combined cataract and glaucoma surgery, we're very liberal about using those particular drugs because we know if we don't, the success rate's rather low. Okay? So we think of this cataract and glaucoma surgery as a nice alternative in patients that have severe disease, uncontrolled disease, or on many medications. And we also talked about cataract surgery being more risky from a lot of standpoints in glaucoma patients. Let's see. What kind of questions do you have? I think you've been asking them as you go. Is there anything we didn't touch on? I think we've hit on everything.
Thank you very much.
Yeah. I'll tell you what, we'll end the formal section because I want him to be able to finish what he's doing back there. And then we can ask some more questions about anything you want. If you want to, we can just sort of rattle around a little bit, and we don't have to confine it to cataract. We can sort of do review questions if you want. Okay? So we'll end the formal session here. So what were you going to ask then?